Thank you very much, dear Chairman, dear esteemed colleagues. I have an easy topic to talk about, and you know it all, so I'll try and make up some time. Basically, the atrial septal defects are about 10% of all congenital heart lesions and 25 to 30% of congenital heart defects that are diagnosed in adults. The surgical approach is very safe, nearly 0% mortality, early mortality, and it's still the first choice, the operation of choice in developing countries. However, in the developed countries, device closure is now the first option. So, according to the ESC guidelines that we all know, to close a defect with a percutaneous technique, you should have all good rims all around the defect. It should be secundum defect right in the middle, not near the vena cava, not near the AV valves, except for the aortic rim. That is a little bit of a myth here in our country. The absence or deficiency of aortic rim is not a contraindication, and it's clearly stated in the ESC guidelines. So whenever we have a significant shunt, whenever the right ventricle is dilated, and even in patients who are diagnosed later and the PVR is even elevated, but anything below 5 Wood units, or when the PVR is less than 2/3 the SVR, we should go ahead and close the defect either with or without a fenestration. The outcome is stated to be better when the operation is performed at, the intervention is performed at the age of less than 25 years. But the patients do benefit even if we do it later, and they benefit from the exercise capacity point of view, shortness of breath, right heart failure, arrhythmias, etc. We should always have in mind when we either close the ASD surgically or percutaneously that the older patient may have diastolic dysfunction, and when you close the ASD, then it may be that the patient goes into left heart failure. So in those cases, the balloon testing should be performed with simultaneous pressure measurement of the LVEDP, and when this goes up after balloon occlusion, then we should use a fenestrated device. The American College of Cardiology in 2008 clearly stated that the ASD patients that have a device closure should be carefully monitored in the first 9 months of life, 9 months post-procedure, but nearly never we do not encounter any complications 1 year after device closure, so only periodical follow-up is suggested 1 year post-device occlusion. We all have discussed and know about the potential of device erosion. We now, in the interventional cardiologists groups, we discussed that these are patients with oversized devices in most of the cases, and the incidence of that is 0.1%. Device embolization is poor selection of patients or poor selection of device size comparing with the device, the defect. The majority of reinterventions, as we said, undergoing transcatheter ASD closure is predominantly up to 9 months after ASD closure. When we have a suspicion that the rims, and particularly the vena cava, and of those two, the inferior vena cava rim is one that we really fear, we interventionists. So when we do have any suspicions that the rim may not be good enough for our device, then we do an MRI. And on the MRI, it's quite easy to see on the black bloods and the SSFP images, the rims on the inferior vena cava, which we do not see very well on the TOE. We do not do ASD sizing anymore. We don't use balloons. For a long time, we go on color Doppler. And occasionally, when we have a difficult defect, we can use 3D echocardiography. I'll skip that. This is a patient of ours with dilated RV, obviously left atrial isomerism, very difficult to see her septum on the transthoracic echo, on whom we closed the ASD with a percutaneous route with a fenestration, which we can order to be 4, 5, 6, or whatever millimeters we want it to be according to our patient's needs. The aneurysmal ASD is not a contraindication for the percutaneous closure. Multifenestrated ASDs, we don't like doing. We don't like putting more than one device in the heart. Prominent eustachian valve, again, is not a contraindication. Moving on to VSD closure, transcatheter closure may be considered in patients with increased risk factors for surgery, although we do know very well that the surgeons manage this defect very well with an operation. But there are some indications where the patient cannot go on bypass, and then a percutaneous technique is accepted. And these are heart team's decisions. Okay, this is not a decision of an interventional cardiologist on his own to go for VSD closure. This should be discussed with the surgeon. The risk of AV block in the perimembranous VSDs has been reported to be 5 to 10%, and this is not acceptable. Perventricular VSD closures can be done. Muscular VSDs are a little easier and not risky. Entrapment of the tricuspid valve may lead to TR, and this again should not be seen, and the patient should not go to the cath lab if this may be a possibility. Again, ESC guidelines clearly state who should be dealt with and how. The location obviously is very important. For us interventionalists, the location is also, the access is important. So for example, if we have apical defects, we prefer to go through the IJ route and create an AV loop from the IJ. And for that reason, every patient needs to be very well worked up. And a plan needs to be made ahead. Obviously, not just congenital patients need our attention. There are post-operative residual defects that we need to help the surgeons and the patients and close them percutaneously. There are iatrogenic VSDs, let's not forget. Sometimes after myectomies, we have seen that, after muscular sub-AS repair. And there are some patients that have septal rupture due to myocardial infarction, and there are registries whether to close the VSD in the hot period after the MI or later on. Often I get asked whether a residual VSD that has not been closed spontaneously but once had some tricuspid valve tissue apposition to it but hasn't entirely closed and fits the criteria for percutaneous closure, whether that's feasible. Of course it's feasible. Most of the times we use the PDA device, which you see here. We put within the aneurysm, and it's perfectly safe to do that. Approaches, results. This is a large registry. I'll stay a little bit on that. Transcatheter closure of congenital VSDs from the European registry, published in 2007. A large cohort of patients, 430, 250 perimembranous VSDs, 120 almost muscular, etc., post-surgery. And these are excellent results. Device embolization only 1%, aortic regurgitation in 3%, tricuspid regurgitation 6%, minor disturbances in 10 out of 430 patients. And you see here complete heart block 2%. That's excellent results really when the patients fit the criteria. This is a post-MI patient that we had at Hygeia Hospital. And immediate post-MI, occasionally we prefer the patient not to do it hot unless he is in shock because of the residual VSD. It is our approach to wait until things settle because the septum immediately after MI may be very, very friable, and going through it with our stiff wires may slice the septum like a surgeon's knife. new devices coming into the market, and periventricular techniques, as you heard from Dr. Mitropoulos, have been practiced quite a long time now. And going on to the last topic, PDA closure. Occasionally a PDA escapes into adulthood, and we have closed about 5 PDAs, adult PDAs in the past year. It is apparent that calcification of the PDA may pose a problem to the surgeon because of the calcification, and in those cases the surgeons do refer the patients to us for device closure, or of course when there are other concomitant cardiac lesions. Even so, even if you have to do something else, the surgeons, and these are from the ESC guidelines, should refer the patient for device closure first and then proceed with the rest of the cardiac repair. Surgery for PDAs is reserved only for the rare patient with a duct too large for a device closure or with unsuitable anatomy such as aneurysm formation. The transcatheter PDA closure is obviously a very old technique. The instructions for use for the devices are in children above 5 kilos. That's with the first generation devices. With the new generation devices, the Untitled additional sizes, procedures have been done in babies as small as 700 grams. We are really pushing the boundaries here. But definitely above 1 kilo, it's quite safe, 1.2. We had at Mitera a 1.5 kilo baby recently that we were contemplating surgery versus transcatheter, but the parents decided for a surgical ligation. Now, it is important to mention that these procedures, either a surgical ligation or a transcatheter PDA closure in these very small and very friable babies that by going to theaters may become hypoglycemic and hypothermic, we should be able to have a setup to do it by the bedside, and that's what we do in our unit. So we go to the baby and the baby does not come to us. So in conclusion, ASDs, newly diagnosed ASDs, consist as much as 30% of the newly diagnosed GUTS cases. Congenital or post-MI VSDs or even PDAs can present in adulthood and can still be hemodynamically significant with or without pulmonary hypertension. The ESC guidelines give us clear indication and support transcatheter closure of the defects in suitable and well-selected patients. And the transcatheter closure is obviously the method of choice when discussed in the heart team. I state that once again, as it is easier for the patient and it reduces patient morbidity and length of hospital stay. Thank you very much.
Thank you, Dr. Tzifa, for your nice presentation. Any questions from the audience, please? I would like to ask you, I don't know if I understood well, but you showed something about 5% AV block, I think. Do you think that it is a good and safe? Oh, right, okay, thank you. Okay. And the second question is, what is the policy anticoagulation-wise, particularly with these devices with the fenestration? Do you think that, thank you.
Yeah, that's actually a very, very good point. When we do have a fenestration, we give anticoagulation. We do not give antiplatelets, particularly in patients with pulmonary hypertension, like my patient with the fenestrated device that I showed you. They may shunt right to left because of that, and therefore we give them anticoagulation.
Thank you. I think that we're a bit late, but we successfully finished with this session.